On behalf of the School of Nursing, Midwifery and Health Systems, I'm delighted to welcome Dr. Joseph Manning to deliver a 1-hour webinar entitled Fostering a Culture of Research in Children's Critical Care. Let me tell you a little bit about Dr. Joseph Manning. Joseph is a clinical academic nurse with a strong and growing national and international profile within the fields of nursing, pediatric critical care, and clinical academic capacity and capability development. A committed children's nurse, Joseph continues to have a meaningful concurrent engagement in clinical practice and research, holding frontline care and leadership roles at Nottingham Children's Hospital and an associate professorship at the University of Nottingham. Joseph is the first registered children's nurse in the UK to be awarded an NIHR ICA Clinical Leadership in 2019 and is seen as a trailblazer in his field. He leads a clinically focused programme of research that has demonstrated impact on the experiences, outcomes and lives of children, young people and their families that access acute care. Specifically, this includes understanding and supporting the holistic needs of children and families in the short and long term after critical illness, the emotional health and well-being of children and young people admitted to acute paediatric inpatient care, and safe and effective transitions of infants, children and young people between services and pathways of care. Joseph has a record of accomplishment in research and clinical leadership that transcend across conventional organisational boundaries. Furthermore, Joseph has more than 4.8 million in competitive grant income, experience of working with international teams, a range of high-quality outputs, and evidence of impact from his research and clinical practice. In 2020, he was recognised by the Chief Nursing Officer for England with a CNO Gold Award for his lifetime leadership and contribution to clinical academic careers and nursing research. Joseph, I very much regret that we're not welcoming you in person to our UCD campus at Belfield, but we're delighted to have you as our expert here this morning virtually. And without further ado, I will hand over to you.
Thank you so much, and thank you for that wonderful introduction. It's a real great pleasure to be invited to speak today and to deliver this seminar. So I'm really looking forward to it. Hopefully it will generate some questions that we'll be able to discuss and explore at the end of the presentation. So I'll just share my screen. Can everybody see that?
Yep, that's fine, Joseph.
Okay, great. So I won't go into any more detail. I think I've been introduced enough. So thank you so much for that wonderful introduction. And I'm speaking today and delivering a seminar on two of my greatest passions, and that's around research or nursing science, and also children's critical care, which is my clinical background and really my research focus in quite a diverse and broad program of activity that I have as a clinical academic. So just want to begin. I'm currently funded by the National Institute for Health Research, and therefore I just need to disclose that the views expressed in this presentation may not be those of the NIHR or the Department of Health and Social Care here in the UK. So over the next probably 50 minutes, what I'm hoping to do is to give some context around the importance of nursing science, and I think look at the global context in which we're delivering nursing practice and the role that research has within that. I then want to do a bit of a deep dive into pediatric critical care as a field. It's a relatively small field in relation to our adult critical care colleagues, but actually it's no less important, and hopefully what I'll do is just describe some of the priorities for research and nursing science within the field, and the things that are important, not just to us as professionals and healthcare providers, but also to our patients and families. And then what I want to do is just to give you a bit of a whistle-stop tour through some of my program of research over the last 10 years that transcend different methodologies, and is sort of focused at mobilizing the patient voice really to advance the science and the care for pediatric critical care, and also pay reference to some of the future directions that research is going to. And then what I want to do is swing back to the title and purpose of this presentation, because it's about fostering a culture of research within critical care, and give you some of my reflections as a clinical academic, as a nurse leader, in how we build and further generate and develop a real substantial culture of research within our field. So I hope that sounds okay for you. So what I want to do is begin with the global, because we see pediatric critical care as this relatively small entity. It has rather low volume but very high cost service, and trying to navigate where it sits in the bigger picture is really important. So I just want to pay reference to this report that was published by the WHO back in 2020. I think it probably went a bit under the radar because of the global pandemic that we saw in 2020 and we continue to see in 2021. But really what this report did was confirm the importance and the vitality of nursing to universal health coverage. And within the WHO report, it sets out this triple billion target, and within each of these domains in which it's trying to address universal health coverage, trying to optimize the health and well-being of populations, and trying to address the new emergencies and epidemics and disasters that appear to be happening around the globe. Nursing is absolutely pivotal, and is a pivotal partner as part of the multidisciplinary team in trying to address some of those global challenges that we're facing in relation to global and universal healthcare. Furthermore, in relation to children and young people's healthcare, the WHO have written a report and published a report around their sustainable development goals around children and young people's health, and embedded within this is women's health. But really it's a mandate to say that in order to improve child and adolescent health across the globe, then we need to be looking at social determinants of health, but also looking at access and provision of healthcare services. And nurses and children and young people's nurses are absolutely pivotal to delivering this plan and achieving better health outcomes for our children and young people. Within that document, they outline this sort of trichotomous vision around survive, thrive and transform, where we think oftentimes that these WHO documents relate to either low to middle income countries or other countries that are not our own, or other services that don't relate to us. And actually what I've done on the slide is try and underline some of the things that relate to pediatric critical care. You know, our purpose is around saving lives, and ensuring that we don't have premature mortality. Whilst people are in our care, that we need to ensure that they have access and coverage to that care, and that they're able to engage with healthcare. And also we bring the science, and part of the transformatory strand of this strategy is around mobilizing the evidence base to innovate, to inform and to utilize and advance technology so that we can continue to deliver healthcare and optimize the outcomes for children and their adolescents. And whilst we may also think that it doesn't apply to us because these are future documents, they may be happening in years to come, actually the future is today, and certainly we're now in 2021, and so both of these documents have real application to the current care that we're delivering on our units within our health systems, in our regions and nations. And so bringing together these two documents, I think certainly for nursing practice, it aligns or shows the importance of 4 key domains, and that relates to clinical excellence, inquiry, innovation, and transformational leadership. And whilst each of these domains have importance, and we can discuss them at length, certainly in relation to nursing science and building the evidence base for clinical practice, that really certainly has real relevance to the critical inquiry domain. And certainly for safe care relies on underpinning knowledge base, and that's really for nurses to be reflective and reasoning critical practitioners, applying what the evidence base is already there to inform the standards and quality of care to their clinical practice, but also to really scrutinise and think about where are the deficits in our knowledge base, in our evidence base, and where do we need to generate further research to advance and optimise the outcomes and care for our patients and families. Furthermore, there's an ethical and safety element to that. And whilst we do have at our fingertips a lot of data, and we're certainly in the era of big data and machine learning technologies at the bedside, and we're starting to mobilize all of that data into intelligence, we do really need to have a critical and inquiring mind around the moral, the ethical, and the humanistic elements, and how that also informs our decision making in addition to the big data and big science. So that's the global picture, and I think there's some real key drivers internationally, globally, as well as nationally, that are shaping what children's nurses and nurses within critical care need to really be focusing on, and research is not going away. It's absolutely pivotal, and the pandemic has shown us that science is our way out of a global pandemic, and that has reference to us as nurses and other health professionals within the critical care domain. So I'm just going to now talk and deep dive a bit into paediatric critical care, because what we've seen since its inception is a shifting focus of what its purpose is, and what our ambitions are with regard to the care that we're delivering. And so I've lifted this from the adult field, but I think it has real relevance to paediatric critical care. And Iwashina and Spillman talk about different revolutions of where we're at and where we're going. So when we first incepted critical care and paediatric critical care, the real focus was on saving lives. Whatever the outcome will be, it's about saving the lives of those vulnerable and critically ill infants, children, and young people. And as we've evolved, we've recognized that actually for some of these children and young people, that actually survival is not an option. And so it's about what we can bring round the bedside, what we can intervene and do within our clinical domain to optimize and enable a good death to happen whilst they're in the critical care environment. And for us in paediatric critical care, we know that this is a very rare occurrence, but it does happen. But about 4% of our paediatric critical care admissions do result in an end-of-life pathway. And then to the current day, which has really been the focus for my activity, is what can we do to optimize outcomes? And I think we're now in the third revolution of paediatric critical care, and really the science needs to be targeted at trying to inform, explore, understand, and think about what we can do that has impact and optimizing the outcomes of not just children or adolescents, but also their families. So over the last couple of years, there's been a number of papers been published within the literature that have tried to identify some of the priorities within the paediatric critical care domain around research. And this paper by Mark Peters from UCL in London did that, and did it by looking around the bed space. You know, as clinical academics or as frontline nurses, this is our gift. We have clinical insights, and we have opportunity to survey what is around us and look at the areas that are of importance, and also where we have a lack of evidence base to really inform our practice and Mark Peters and colleagues did this really nicely within this paper in looking at some of the key domains of paediatric critical care medicine, looking at systems and support and interventions, and thinking about where do we need to focus our energies in building the evidence base so that we know what is effective, when it is effective, and who to use it on to have the best outcomes. Furthermore, and more recently published in Pediatric Critical Care Medicine last year was a prioritisation Delphi study that was conducted by Professor Yvonne Toom and Dr. Julie Menzies and colleagues on behalf of the Paediatric Intensive Care Society in the UK. And what they came up with, they didn't just look for what were the priorities for health professionals, but actually what were the priorities from a parent perspective. And although this is a pretty busy screen, what it shows is the top 20 priorities as ranked by healthcare professionals and by parents. And I think, this is really important to me because my program of work has been really driven by mobilizing the voice of those often unheard, and that is of parents and families who have been critically ill. And what's interesting is that on some things there's comparability across healthcare professional priorities and those of parents, but oftentimes there is incongruence between the two ratings, and that's of interest because it doesn't always mean that we've got clear alignment between what we perceive as a priority and what is the priority of our families. But of really great point for me is that, within that top 20, there were two that related specifically to understanding, exploring and optimizing the outcomes for parents and families post-critical illness. And I suppose what I would argue or challenge is that probably all of these other priorities link to optimizing outcomes, humanizing care, and ensuring that the effectiveness of critical care interventions ensure that we develop and optimize the physiological status as well as the emotional and psychosocial outcomes for children and families after they've been through the critical care unit. So I think that's really useful in understanding where our priorities are as a critical care community, and certainly as our patient characteristics, and we've seen this during the global pandemic that we've had a bit of a shift in who we see coming through the PICU, what their disease groups are and what's their modality of admission, as well as what they're requiring from the PICU. So it's really important that we continue to evaluate and re-evaluate what those priorities are over time, because they will be changing over the next 5 to 10 years. And it's important that we're cognizant of that so that we're developing the science that aligns and has greatest impact on clinical care. But I think also it's about utilising our clinical insights as people working at the bedside to drive forward the clinical questions that we're asking of the research. And certainly that was the starting point 10 years ago for my doctoral journey and subsequent postdoctoral activity, was around the dissatisfaction that I felt when I was answering the questions that parents had around the prognosis, what the outcome would be for these children and families that I was caring for. And when I went to the literature, it was pretty scant. And so that was the starting point. And as this title slide shows, we conducted a systematic review as part of this developing program of research, trying to understand what were the accounts and the psychosocial impact of surviving critical illness from the perspectives of children, because they were very limited within the literature. And from the 3 studies that we identified, that actually children's voices is predominantly neglected, but their survival trajectory is potentially complicated and related to a range of different domains and trajectories according to the social circumstance, the understanding of what happened to them whilst they're on the ICU, and also their outcome subsequent and support post-critical illness. So from that systematic review and that really robust look at the qualitative literature, that led on to some of the doctoral work, which was around, which is called the Sketch study, which was looking at longitudinal accounts, and it was a prospective longitudinal study of psychosocial well-being of children and families post-critical illness, and we utilised a very in-depth exploratory qualitative approach using multiple case studies as well as narrative approaches to try and elicit these children's stories of their survival. And for me, it was really important to try and include children that had oftentimes been excluded from the literature, that were part of our critical care population, and that included children that were very young and children that had neurocognitive impairment or communication difficulties, because invariably they had been excluded from other research studies. And actually it was important to try and utilize innovative and participatory approaches to liberate and harness their views and experiences. And so we did that through what was termed as a toolbox of methods, but included photo and graphic elicitation techniques to harness their narratives, as well as sort of a responsive interviewing technique. And from that work that you can see was published in Journal of Child Healthcare, that we captured the accounts for the first time around survivorship from children and their significant others, which included parents, siblings and grandparents from 6 to 20 months post-PIC discharge. And their narratives were quite diverse, but restoring them was an important part of confirming their well-being. And whilst there's a huge amount of negative outcomes reported within the literature, actually from these children and families accounts, that there was positive aspects of survivorship that until now had rarely been reported within the literature. But there were also traumas and readjustments that related to their psychological and social well-being. And so that sort of gave rise to thinking about, well, what can we do to help support these children and families? And for anybody that's done a doctoral journey, you go in with one question and you come out with 50. And that was certainly the case for this piece of work. So that led on to really re-engaging with our patients and families and other key stakeholders to try and identify, okay, well, what are the priorities here when there are so many questions unanswered and so many priorities that we need to tackle? And so we did some stakeholder engagement work where we ran some workshops with a whole variety of stakeholders to try and identify these priorities. And this came up with this framework around, there were lots of priorities around process, but also lots around outcome, and thinking about how we can support, identify families that have outstanding needs, and where are those points in their transition out of the PICU that we need to support them. How do we screen for negative outcomes, and how do we signpost them to existing services or develop new services that are effective at mitigating or minimizing the negative impact? So that was a really useful exercise, and it challenged us to think about, okay, well, what's the state of play with regard to the policy and the practice landscape? And we looked at the in adults, you know, the National Institute for Health and Care Excellence have developed a really robust quality standard for what rehabilitation adults should have, and what follow-up after after adult ICU discharge they should receive. But there wasn't anything comparable for pediatrics. And so that really led us on to the next step, which was to look at what was the provision, because we know that whilst we've got a rather good networked approach around critical care provision, what's happening and what's the role of the PICU in the follow-up and aftercare for these patients and families. So I think 2018 it was that we conducted a cross-sectional study survey using a validated survey that had been developed in Denmark that we translated into English, and we administered it via a web-based survey. And for those non-respondents that we tried to access them through a telephone administered survey. And we tried to get all PICUs to be involved in the study so that we could have a comprehensive overview of what was being provided to these patients and families. And so what that resulted in was actually a real deficit in the longer term follow-up care for children and families after they've been discharged from the PICU. For those sites that did deliver follow-up, and that was 4 out of the 22 respondents identified that they provided some sort of longer term follow-up. There wasn't any clinical guidelines, there wasn't any criteria of who received it and why they received it and what they received in relation to the intervention. And so what that led us to think about and scrutinize, that we didn't really have any good and comprehensive program around what we were supporting what we were delivering to these children and families after they left the PICU. And what the survey identified was that there was little confidence and a lack of recognition of the importance for long-term follow-up or aftercare for families, because the evidence base wasn't there. And so that led into 2 strands of work. It was around the time, so in 2012, in the adult ICU world, Dale Needham at University of Michigan and team developed something called post-intensive care syndrome that conceptualized it. And from that work in 2012, it's really generated clinical and research utility in driving forward the agenda for post-ICU follow-up, in recognizing that it's a public health burden and trying to develop the scientific evidence as well as the clinical practice to improve and optimize the outcomes for adult ICU survivors. But there wasn't anything comparable within the pediatric field. And so myself and an international group of colleagues that were involved, clinicians, nurse scientists, clinical psychologists, came together and conceptualized for the first time something called post-intensive care syndrome in children, or Pxp. And really that framework was useful because it started to illuminate and give a framework for what was very complex and fragmented in how we'd previously looked at it within the science and within practice. So this is the Pxp framework. Some of you may have seen it, some of you may not have, but really it just talks about this interconnected phenomena and sort of emanates the care pathway for the child coming through the PICU, their baseline status prior to the PICU admission, coming through the PICU, and then thinking about the types of outcomes that they may have and what sort of domains it fits in, whilst being cognizant that this is children are on a developmental trajectory, and the potential impact that having a critical illness and being exposed to the ICU may have on them that relates to days and decades. So just a brief overview of the framework, but we know that the antecedents or the baseline characteristics, that we have a varied population that come into the PICU that differ according to their medical history, their functioning and socioeconomic status, that they're on a developmental trajectory, and so they're on a dynamic state, and that may have impact on the potential outcomes and recovery and rehabilitation post-critical illness, and that they are part of a family unit, and family units differ in composition and in status and socioeconomic status, but we know that the interdependence on that family unit is absolutely critical to that child, and may impact on their health outcomes post PICU. In relation to the phenomena, so being on intensive care, what we know, and over the last 10 years, there's been growing evidence of the iatrogenic harms that can occur whilst children are critically ill, that they are in receipt of PICU and they're exposed to these very strange environments. And certainly, again, Washington and colleagues have tried to conceptualize that within the adult literature of what what happens to an acutely ill adult, and we know, and there's growing evidence within the paediatric field, that there is malnutrition, deconditioning, delirium, and impact on the family whilst that child is in the intensive care and been critically ill. Furthermore, for the parents, there are numerous stressors that have been reported whilst they're experiencing a PICU admission. These are potentially being heightened and exacerbated during this pandemic state when we've got real restrictions over visitation. But it warrants a number of needs that they have whilst they're in our care. And also for the siblings, and I'm really passionate about another very unheard and an unexplored population, but siblings also have some very discrete needs that cannot be overlooked because they are part of the family unit and therefore part of the phenomena. And invariably, they are isolated and uninformed in relation to the PICU experience oftentimes. So that's the phenomena, and then it leads us to the outcomes. And the current evidence base is around that there is some evidence that children and their families can be affected in relation to their emotional and social health outcomes. They can have impaired health-related quality of life, and for the child, they can have functional disability as a result of being exposed to the PICU and the iatrogenic harms of being critically ill. But there are a huge number of limitations with the current evidence base around this, that we've, from the evidence base, it's evident that we have only explored certain outcomes for certain patient groups with different medical conditions. And we haven't really looked at the PICU populace as a whole. We've looked only at specific age groups, and we've rarely assessed baseline. So we don't know what that critical illness state is, invariably, because there are emergency admissions, but that's really important in understanding trajectory of outcome and what can be attributable to the PICU admission and what's attributable to other life events and their pre-critical care state. And we haven't really looked at the outcomes across the myriad of domains, and certainly the big players here is we've got quite a good understanding around the physical and cognitive outcomes, but not very good understanding across the physical, cognitive, emotional, and social health outcomes. And until recently, there has been no consensus around what outcomes we should be measuring in the instruments used, and no consensus around the time points that we should be measuring those outcomes. And certainly there's been very limited follow-up. So we don't really understand what the long-term impact of critical illness and ICU survivorship is. So then I moved to the current state, which is my current study, called the Oceanic study, which is an NIHR funded large study, multi-center study that's trying to map the outcome trajectories for children and families post critical illness, and it's a mixed methods study. So as I say, we're trying to look at all of the outcome domains and trying to map the outcome trajectory for not just the children, but also the other significant parties in that family unit, namely the parents and siblings, so that we're better informed as to understanding what outcomes are affected and what the natural history of those outcomes are, so that we can intervene, look at modifiable factors, and think about how we can configure our care whilst they're on the ICU and what happens post PICU discharge, so we can target interventions to really optimize their outcomes. So as I say, it's a longitudinal mixed methods study. So we're recruiting families into the study and exploring their health outcomes across those 4 health domains over the first year post-PICU discharge. We're also doing some data linkage with PICANET, which is the National Audit Database, to try and think about what are the modifiable factors that happen on the ICU, what interventions are we implementing, and what impact does that have on outcomes, and whether we can do anything whilst they're on the ICU to really optimize their longer term outcome and lives. And then within that, because it's a mixed methods study, we're selecting a number of families based on the primary outcome measure, which is the Pediatric Quality of Life measure. And we're doing some really in-depth interviews with these families to try and understand what are their health needs and roles over time. So again, using sort of participatory approaches, responsive interviewing, as well as a toolbox of methods to try and elicit the diverse and well, the potentially diverse accounts of these children and families, to try and understand and get a greater understanding and contextualize some of this quantitative data that we're collecting around health outcomes. And so what we're hoping with regard to this study is that it will provide us with some generalizable results, identifying who is at risk of developing negative outcomes when these morbidities manifest, and who does it manifest in, and whether there are anything that we can change or do to improve those outcomes. Certainly with the embedded qualitative study, that will give us some transferable findings around caregiving roles and needs that will direct future research around the development of interventions and what we can do to help support these families post PIC discharge. So what does the future hold? Well, I think we're still in this global pandemic, and there's been tremendous burden on healthcare systems, and some things have changed for the good. The fact that we're able to engage in a virtual capacity today is probably some of the things that will stay beyond the pandemic and into this new normal. But also it's put a real spotlight on critical care across the life course, and really sort of illuminated some of the fundamental care that we're delivering, the humanized care that we provide as within our paediatric care in critical care environments, and really allowed us to scrutinize that, and what does that mean, and how do we ensure that it's delivered to the best quality to those people that need it. It's also brought some challenges that I think will really influence and impact on the health outcomes of patients and families. There's been huge disruption around the provision of paediatric critical care. We've implemented at pace some measures that have come under the infection prevention control precautions, but have corroded some of the things that are part and parcel of paediatric critical care nursing, and more widely child health nursing, and that's around family-centeredness and family-centered care. So restricted visitation and the impact of that we're yet to see, but I think that's going to be something that we're going to have to contend with within this new normal. And also it's really put a spotlight on the rehabilitation and the longer term outcomes for patient and families, and hopefully we can mobilize and utilize that platform to really gain momentum, not just within the adult domain, but also within the paediatric field. So for me, the Oceanic study that we're currently delivering, we're recruiting into that study, that's due to finish in 2023. We also do have a sister study that's being led by Professor Martha Curley and Dr. Scott Watson in the United States. That's a comparable study where we're collecting the same health outcomes, so that hopefully we'll be able to do some uniting of the data sets and some multi-level modelling to look at the differences in healthcare outcomes in relation to health system, to really try and drive forward this agenda and develop and test hopefully some interventions that will optimise the outcomes for our patients and their families. But for me, it comes back to our patients, and really the central sort of ambition and desire for me to do all that I do, whether that's in my clinical domain as a critical care outreach nurse, or whether it's in my clinical academic domain in driving forward the evidence base, is around trying to improve things for our patients and families. And this is a quote from one of the parents that's a part of my patient and public involvement group for the Oceanic study, whose son was admitted to the PICU coming on 30 years ago. And still they're contending with some of the issues of that, the adversities, the psychological and social challenges that having a child on the ICU brings. And so that reconfirms in my mind that this is absolutely an important program of work that needs to be driven forward, and that we need to get to a state where we're developing and testing the interventions so that we can try and mitigate some of the adversity that Deborah has felt and her family have felt as a result of being on the ICU. So that's the program of research and a flavour of some of the work that I've been doing that transcends methodologies, but has been really focused on mobilising and liberating the voices of our patients and families. And I firmly believe, and it's been confirmed regularly throughout those 10 years, that this is a really important area that we need to be focusing on. So I just want to end by thinking about some of my reflections in building a culture and building a program of work, and what that means within the paediatric critical care community. And I think certainly for creating a culture of PIC research, that really starts with dissatisfaction with the status quo. So, you know, as Steve Jobs says here, do not compromise. And I think it's that dissatisfaction, it's that uncompromising stance that really helps to drive forward the agenda and foster an ambition to do better in relation to our patient care, better in relation to the quality of care that we're delivering, and better in relation to the patient and family outcomes that we want to achieve. And this is an uncomfortable position to be in, because it's challenging the status quo, but that fosters in its own right a culture of curiosity, ambition, innovation and improvement. And by being uncompromising, then we're going to advance the science and the status quo for our clinical care. And that's what's going to be able to lift us to a position where we can ensure that we're optimizing the outcomes for our patients. The next thing is around science. So, you know, I've talked, because I'm a nurse and very proud to be a professional registered nurse and a children's nurse. That is the standpoint in which I view the world. That's the frame in which I try and bring to my research and to my clinical practice. But actually, we deliver care as a team, and therefore, whilst care is a team approach, science is also a team approach. So it's all about team science. And I mean that in the broadest of terms. Whilst our conventional team is health professionals and managers and academics and other researchers, that's absolutely key. But also pivotal to that and central to me is our patients and families. And when I say team science, it's about teams that transcend not just at a unit level or an organizational level, but it's also healthcare system, it's regional, national and global. And certainly paediatric critical care is very much a relatively small field, but has a very vibrant, nurturing and engaging global community. And like the challenges and the benefits that the global pandemic has brought us, technology can break down conventional geographical barriers to engaging and collaborating with people. So I think, you know, think big, think outside of your unit, and really the way in which we can achieve true impact is by fostering a team science approach. So to conclude, I think that science absolutely has to align to not just professional priorities, but also to the priorities of our patients and families. And we've got clarity over what those priorities are in relation to the field of paediatric critical care. Because if we align to those priorities, then we're going to you know, ensure that we can have the most impactful research. Every nurse's business is about developing and embedding research culture. And I mean that in relation to the whole spectrum of what evidence or science means to us. So whether that's generating or, undertaking research and leading programs of research, or the implementation end, which is absolutely impactful. We have a responsibility as nurses and other health professionals to mobilize the science for our practice. Because without that, then without nursing science and without science general, there is no advancement to our professions, to our field or specialty of paediatric critical care, and to our clinical practice. And absolutely our patients and families deserve this, and we deserve this to give them the best available evidence-based practice. So I'll leave you with this picture because, no way 10 years ago did I think that I would be presenting today to you, presenting a seminar and talking about a whole program of research that's been developed focused on trying to improve and understand the outcomes of children and their families after they've been discharged from the PICU. So think the unthinkable, and dream big, because don't be surprised if your mind is blown. Thank you so much.
Thank you so much, Joseph. I can't tell you how much I enjoyed that presentation. I feel inspired and motivated. It's not just the bucket of coffee I drank this morning. It's certainly the words and the research you've included, the way you went from from a global picture right down to an individual level. And we all have a role, and we absolutely do. And sometimes I wonder, do we underestimate ourselves, or do we not believe what we can achieve? And the wonderful thing is now we are reaching out beyond geographical boundaries, as you say, and everything is on the table because we can collaborate. We do not need to be restricted by a location and a jurisdiction. And the fact that you're here speaking to us today just proves that. And we are central, and we have so much potential. And maybe it is a benefit that we are a small world, and compared to adult intensive care, we are quite a small number, but very important with potentially great impact. So I will not hog the mic any further because there are a lot of questions coming in. And I would just take the first one from Rachel. Joseph, have you seen pet therapy in practice in ICU, and do you see a role for this for children and their families more longitudinally at home?
So yeah, I think definitely seen pet therapy. And when I started on the PICU a number of years ago, we did have we had some fish, but prior to that, we probably had a whole menagerie of pets that were in the playroom on the PICU. So I think there is growing evidence to say, to show the therapeutic value of pets within the ICU. There's some great work by Sapna Koducha in the US around early mobilization and the use of pets. And I think, there certainly is a role within that. But I think it's part of a whole sort of bundled approach to how we humanize the care that we're delivering on the ICU. And I think that's where we probably will see the greatest value in these interventions, is if we look at, so there is the ICU Liberation Bundle, which is the A to F mnemonic, which talks about, the importance of family and their therapeutic interventions that they play, the role that they have. But yeah, I think there is definite scope for pet therapy within the ICU and thereafter. I think there's much that we can do around trying to help support these families and using innovative approaches once they've left the PICU to understand and frame their experience and how they can move on from that in processing it from an emotional perspective, but also how they can resituate and reestablish their lives once they've left the PICU.
Fantastic. And Rachel, how is a PhD candidate looking at exactly that issue? So maybe Sapna is somebody that would be worth linking in with.
Yeah, I think this is where you see the value is where do you dovetail into the bigger agendas? And I think your point, Claire, in thinking that yes, we are small in relation to numbers, but actually the interconnectedness with other agendas makes us stronger. So we need to look outside our convention and think and draw the linkage. Because we're better together. And for me, it's about drawing the linkage with things around the mental health agenda, things around the rehabilitation agenda, things around the adult ICU and the life course approach, thinking about how do we frame survivorship, not just for the child, but also this may be 3 or 4-fold impacted, and this is days to decades. So if we don't do early intervention, if we don't optimize outcomes, then we're going to have, there's going to be impact on the welfare state, there's going to be economic impact, there's going to be social and societal impact. And I think that's really where we need to mobilize and frame our agenda, because then it takes it from this very small specialty to actually this is everybody's problem.
Absolutely, absolutely. I have a comment and then a question relating to what you've just spoken about there. Firstly, Catherine Redmond, who is in the Faculty of Nursing and Midwifery here, inspiring to see how a PhD question can lead to a full programme of research, the snowballing effect. And then a question from another colleague, John Gilmore. Thanks so much, Joseph. So much overlap with adult critical care environments. While you've outlined lots of transferable knowledge and practices, I'm wondering about your thoughts on more collaborative research, the potentiality and barriers. And that, I presume, is the collaborating with adult intensive care. Yeah,
so I think it's paying reference to what I've just said in that, we're better together, and I think we need to make the explicit the synergies with adult ICU survivorship. Certainly the inspiration from Dale Needham's work in conceptualizing post-intensive care syndrome has been really useful. But we have to also recognise that there are some considerable differences between adult and paediatric and child and family survivorship post-critical illness. I've just published an editorial with an adult psychiatrist from Australia looking at a life course approach to survivorship and outcomes, and that's just been published in Nursing and Critical Care. And within that, we do appraise some of the synergies between the adult ICU literature and the paediatric, and where we're setting our horizons. And I think there will be more commonality going forward as we unite our efforts to try and address this massive agenda around survivorship and optimizing outcomes. You're muted, Claire.
You're muted there, Claire.
Oh, sorry. A COVID-related question. Now, it might be different in the UK as your vaccination programme is farther ahead. But Niamh is asking if you see visiting restrictions remaining in place as they are at present with COVID. For the RPICUs, there is one parent at a time allowed at the bedside. And what can we do to support families with this restriction?
Yeah, so I mean, this is the same in England, and certainly in my unit, that we have restricted all visitors across the whole children's hospital, so any inpatient, to one parent at the bedside. But I think it is starting, the issues and challenges that we're facing is starting to rear its head, and the dissatisfaction with this status quo is starting to emerge. I think, this is where we need to start lobbying and mobilizing the evidence base to challenge back. I mean, I'm not overly confident around the evidence for implementing this intervention, but absolutely we need to get back to what we had before, because we practice family-centered care, and we know that to optimize outcomes, and it's been evidenced for early mobilizations. There was a big European survey saying that actually early mobilization occurs if the parent's at the bedside. So we need those families at the bedside, and we need to claw back that practice as soon as possible. So I think it's again looking at and challenging the literature and using the evidence base to pose a case for getting back to normal and ridding ourselves of some of these practices that have come in at pace and scale that really undermine what we hold, important, which is family-centeredness.
Absolutely, I think that's a very important message. Keep questioning and use the evidence as well. We have another question about COVID. Have you had to adapt your research methods as a result?
Yes, so we've just come out of a second pause to the study because of COVID, and that's not because we couldn't run the study, it's because we couldn't deliver it because of the research nurses were pulled to deliver COVID priority urgent public health studies, which unfortunately Oceanic wasn't part of the portfolio of. So we have had to be a bit agile in how we're delivering the study, and we've had to use the virtual platform to do the embedded qualitative component. So that's the main change for us in relation to the delivery of the study. But what we have also done is understanding the context, and people's lives are, my life is chaotic, and I haven't had a child that's gone through the ICU. So I cannot imagine, and it's about trying to frame and understand the complexity that exists within these findings within a pandemic context. And so we've added in some additional lines of inquiry through those qualitative interviews to try and unpick some of this additional complexity that the pandemic state is imposing on these families' lives, because we know that there's been limitations to accessing services. There's been obviously school closures and homeschooling and unemployment that are factors of social determinants of health, and these may have a bigger impact on the health outcomes and also the experiences and needs that these families have post critical illness.
Very good. Thank you for that. Another question here, it relates to spirituality. As nurses, we strive to care for our patients holistically. From your research, have you found the care of spiritual needs to be important in the care of the child and family post-ICU?
So yeah, I think absolutely that it's really difficult to untangle the spiritual domain, the cultural domain from the experimental domain. But absolutely there's elements of spirituality that come through in these, certainly the in-depth qualitative accounts from my PhD work and subsequent work of these families. And we've currently got currently supervising a PhD student from Singapore with Professor Jos Latour at the University of Plymouth that's looking at the impact of culture and spirituality and religion on health outcomes post-critical illness. So I think there's definite scope to look at that further and look at the notion of culture and ethnicity and also spirituality in relation to health outcomes and survivorship within this patient population. But without doubt that there is an element of that is important to these families.
Very good. I have one more question. We've about a minute to go to 11. And this one is from Rachel Howe, a colleague of ours in the School of Nursing. Joseph, have you heard of reflective diaries for families supporting their child in ICU? The value of therapeutic diary keeping for the parents, and then to read and debrief with at a later date, perhaps at home.
Yeah, so I mean, there is some work around the diaries that Fiona Lynch is doing currently under the supervision of Jos Latour and the global community, and I think there's real value in them. From the PhD work, some of the diaries are diaried through a certain perspective, and that may be written by a parent or from a perspective of a nurse, and I suppose the framing of that and the viewpoint and what is narrated within the diary differs according to who's writing it. And so from the PhD work, some of the families felt it very challenging to engage or re-engage with that content. And so I think we probably need to understand a bit more. I think there's definitely a place of diaries and the therapeutic restoring of them, but it's about it being the right time that they re-engage with that, and in the right format, and there being voice and choice around that. But again, I think there's some real value in those diaries, and that's evident from the literature, and hopefully from Fiona's PhD work that's about to emerge.
Thank you very much. Lots of food for thought there. We have no more questions unless anybody wants to. Well, we're out of time anyway. But can I just say, Joseph, you're getting a lot of love from not just here in Ireland, but also your colleagues in ESPNIC, Anita de Jong, Hannah Collins-Rigney, it's maybe some colleagues across in the UK as well. We really want to just say how grateful we are to you for giving your time and presenting such wonderful data and inspiring and motivating us all. Please do contact us if we can be of any support to you with any further studies, any future collaborations. We're here to support one another and to advance the care and recovery of children with critical illness and their families. So thank you for sharing all your wonderful work. You have just inherited quite a few Twitter followers over this side of the world as well now. So I'm sure your number will grow even more. And thanks again. We'll hopefully keep in touch and have a good day. Enjoy the sunshine.
Thank you so much. Thank you for your time.